Hello, everyone, and welcome to today's Dementia Researcher Salon Debate. I'm Adam Smith. I'll be your host for the next hour. Thank you very much for joining us here in the Dementia Researcher community. And today we'll be debating a question that sits at the heart of how we shape the future of dementia research. This House would redirect funding from biomedical dementia research to social care research. Speaking for this motion, we have Nancy Brown, a dementia care researcher at the University of Edinburgh with over 18 years frontline experience. Her work focuses on social care, community inclusion, and using ethnography to understand lived experience in advanced dementia. Hi, Nancy. Thank you very much for joining us.
Thank you.
And speaking against this motion, we have, welcome back. I think Soraya has been with us before. We have got Soraya Meftah, who is a postdoctoral researcher, or am I allowed to say research fellow now? Is that?
Not yet. Incoming research fellow funded by some nondescript.
Oops, sorry.
Right.
At the University of Edinburgh. Her research investigates neuropsychological dysfunction in dementia through human and rodent models using electrophysiology functional assays to explore synaptic change. Is that right?
Yeah, enough.
Well, thank you very much, both of you, for being here. Let me start by explaining a little bit about the format if this is your first week in joining us. So each speaker will begin with a 10-minute opening statement to present their case. Then we'll move into 15-minute exchange and rebuttal, where I'll invite each speaker to respond to the other's comments. And at that point, then we'll also open the floor for your questions, where we hope you'll put your questions forward. We have 15 minutes for Q&A. We'll select your questions from the chat, or you can use the Q&A button at the bottom of your screen if you're watching on a web browser, or I think it's on a tab along the top if you're using the app. And then finally, we'll ask each of our speakers to give closing remarks, and we'll end with a final audience vote to see how opinions change. But to start with, we're going to invite you to cast a vote now. And I'll share my screen so we can see how things are going. So in the Q&A there, you will see is a chat, is a link rather, to where you can vote. And I'm going to share my screen so we can see how the audience sits. So here we are. So reminder again that we're asking, this House would redirect funding from biomedical dementia research to social care research. And so far, we've had 8 votes, so not too many. So 50% agreeing with the motion that they would redirect funding, so in favor of Nancy's position, 38% with Soraya, and 13% undecided. So all to play for, I feel, in this. And of course, I want to start this by saying, of course, these debates are to spark conversation and discussion. That of course, in an ideal world, I'm going to steer this from the outset, we should be funding all of this kind of research. But it's really interesting to have this discussion and to see where we sit on these issues. So I'll leave that poll open for a few minutes longer. Just not too long while Nancy's talking, because I don't want to sway things. I'll leave this open for the first couple of minutes of Nancy's talk, and then I'm going to close that down for any latecomers. And then we'll come back and we'll ask you to vote again at the end. But in the meantime, I'm gonna shut up and hand over to Nancy. Nancy, over to you.
Hey, thank you very much for this amazing opportunity to be part of this discussion, debate. Every 3 seconds, somewhere in the world, someone is diagnosed with dementia. But for the over 55 million people already living with dementia, there is still no cure. And for too many, there's also no guarantee of good care. We've invested billions in the promise of future treatments. At the same time, those living with dementia today often face isolation, loss of connection, belonging and purpose, as well as a care system stretched to its limits. While the pursuit of medical research is important, Tonight, I want to argue for balance. It is our moral, economic, and scientific responsibility to rebalance our priorities, to shift our attention, imagination, and funding toward the question that matters right now. How can we help people live well with dementia today and not just wait for a cure that may never come? The first reason to rebalance funding is moral. Quality of life, dignity, and social inclusion are immediate moral obligations. We have a duty, not just as researchers and professionals, but as human beings, to improve the lives of people who already have dementia. For them, the future is not 10 years from now in a laboratory. It is tomorrow morning at the breakfast table or this afternoon in a care home lounge. Non-pharmacological approaches such as music, movement, reminiscence, art, validation give people moments of cognition, laughter, and recognition, even in the later stages of the disease. They remind us that presence is possible long after memory fades. I have over 20 years experience in a memory day center. I'm a practitioner and now a researcher as well. And throughout those 20 years, I've worked primarily with people living with advanced dementia, absolutely extraordinary people that still have so much to give and so much to offer. During the COVID-19 lockdowns, when our Memory Day Center was closed, we moved our activities online with a variety of music and movement. I then wondered if my clients living with advanced dementia could engage in a small online group. The results were remarkable. They recognized one another through the screen. They smiled, sang together, reached out their hands, shared items from their home. The digital space, far from being sterile, carried warmth, humor, and belonging. Those moments did not come from medication or biomedical research. They came from human connection, supported by culturally adapted design, empathy, and creativity. This is what social care research studies. It strengthens and makes possible on a larger scale. Cure without care is hollow. Our first moral obligation is to care for those who are already here. The second argument is practical and economic. Biomedical research commands the overwhelming majority of dementia funding. Yet after decades of extraordinary investment, we still lack a treatment that meaningfully changes the lived experience for most people. Meanwhile, care systems are collapsing under pressure. Family caregivers are exhausted, along with significant financial burden and effects on their own quality of life. Professional carers are underpaid and undervalued, and the costs of institutionalization, hospitalization, and crisis admissions rise year after year. The 2025 Alzheimer's Disease International Report estimated by the year 2030, less than 5 years away, the cost of dementia care in the United States will increase to $2.88 trillion. Think about that, $1 trillion. Redirecting even a modest portion of biomedical funding, even 20-25%, could transform these realities. We could expand training for everyone: nurses, emergency room personnel, doctors, therapists, technicians, carers, families, and also fund community-based programs and implement proven interventions that keep people at home longer, reducing hospital stays and nursing home admissions. This is not just compassionate, it's cost-effective. And every day of avoided hospitalization, every month of sustained home care saves systems money while preserving dignity for the older person living with dementia. Investing in care is not a charitable act. It's also sound economic policy. The third argument is scientific and evidence-based. For decades, dementia research has been dominated by a single paradigm, the search for a cure through biomedical science. That pursuit is vital, but it is also incomplete. We have learned that dementia is not only a disease of the brain, it is a condition of relationship, environment, and meeting. Human connection, culture, and context profoundly shape how people live with it. Social care research is science too, rigorous, evidence-based, and replicable. Studies show that music therapy, validation, culturally adapted engagement improve mood, communication, and quality of life. These effects are measurable in facial expressions, engagement levels, caregiver stress, and reduced medication. Funding social care research would follow these interventions to be tested with the same rigor and scale as biomedical trials. Yet these studies struggle for funding precisely because they do not fit the biomedical mold. If we truly value evidence, we must fund the research that generates it. That meaning gives psychosocial and community interventions the same scale and respect we give to pharmacological trials. Evidence without empathy is incomplete, but empathy studied well is also evidence. And the fourth reason is global. Biomedical research benefits mainly those in wealthy systems. Over 60% of people living with dementia live in low and middle income countries, places where access to advanced drugs or imaging technology is minimal. For them, the promise of a cure means little if basic care and community support are unavailable. A rebalance in funding is not only ethical, it's equitable. Investing in social care research helps develop culturally adapted, locally sustainable interventions that work anywhere, whether or not a hospital is nearby. If we want dementia care to be just, it must be possible everywhere. Thank you.
Very compelling argument. We'll hear from Soraya now, who's going to make her own compelling arguments. And your 10 minutes is here now, Soraya.
Great. So, as introduced, I am Dr. Soraya Meftah, and I have been working in the dementia research space for just over 10 years. And I've looked at drug discovery in my kind of earlier days, moving now on to kind of human and rodent models of dementia. And I think, therefore, I have a kind of really good footing in this field. And I'm, of course, speaking for the motion, so in support of funding biomedical science research compared to social care research. So to start, I want you to imagine a world where a diagnosis of dementia isn't just a diagnosis that we're resigned to, where we can't do anything about it. You know, with biomedical research, we can move beyond this to a world where we don't just try to manage the symptoms of the person living with dementia and adjust to the kind of symptomatic decline that we know they'll get, but we can actually stop the decline in its tracks. We can identify people who may go on to develop dementia and prevent this from happening or cure it if it does. This is really what we gain from biomedical research, work towards cures for these diseases that cause dementia. To open, I want to start with what I believe is the strongest point for biomedical research, and that is that it offers the developments of cures for diseases. We're finally at this kind of critical point in dementia research where we have the first disease-modifying treatments for Alzheimer's disease. With this kind of new generation of approved amyloid-targeting drugs, lecanemab and donanemab, we know that whilst these drugs have kind of modest effects, they show a statistically significant reduction in cognitive decline. So, for example, donanemab showed a slowing of cognitive decline by 35% over 18 months. You know, for 30 years, we have had this kind of decades of biomedical research, but for 30 years, the amyloid hypothesis was just a theory. But now what these drugs provide us is a critical proof of concept that we can actually target disease biology and therefore change disease progression. And really, this is crucial validation that biomedical research is on the right track. And whilst this is just one component of disease targeting within Alzheimer's disease, we have 182 clinical trials, according to Cummings et al. 2025, with the majority of these targeting biological disease mechanisms, with 48 of these being in phase 3. And this pipeline is not just amyloid either, or not even just tau, for example, within Alzheimer's disease, but this addresses a diverse range of biologically relevant disease mechanisms. So, for example, we have neuroinflammation, synaptic plasticity, and even developing areas such as kind of the gut-brain axis. And broadening our focus past Alzheimer's now, we've also seen really exciting developments in other disease areas, which have had impressive results, such as the clinical trials for Huntington's, with AMT 130 having a 75% reduction of symptoms over 3 years in a phase 1 trial. And whilst this is still early, and whilst Huntington's is a rarer cause of dementia, I think this is really showing that we can start to target these diseases with pharmaceuticals and provide some intervention for disease progression. And this can only progress by funding biomedical research. And really, I don't just think that, but of course, the other charities across the UK, at least, for example, Alzheimer's Research UK, have echoed this sentiment as well, with their newer slogan, "For a Cure," which really emphasizes this as well. Now, of course, when we think of biomedical research, we may just be focused on a cure, but biomedical research has provided us with a wide wealth of information on the diseases itself as well. So, for example, biomedical research gives us ways to identify people living with these diseases earlier. So historically, people thought that maybe this was just a kind of diseases of aging, or just kind of what happened when you got older, and that it was just part of what happened. But really, biomedical research has given us biomarkers, for example, the PET tracers. So we have amyloid PET, tau PET. We have these other developing tools in the pipeline as well for diseases outside of Alzheimer's as well. And we have blood biomarkers, so plasma amyloid beta 4240. We've got the phospho-taus that have been coming through the pipeline as well, such as, and also the kind of newer blood biomarkers that are being looked at as well. These have allowed us to really identify the populations accurately and diagnose people with precision. And this allows us to identify at-risk populations for preventative social interventions. And social care research relies on some of these tools provided by biomedical research. And this also has given us an added benefit of allowing us to refine clinical trials based on biomarkers, for example, really meaning that we can focus these therapeutic trials on those populations that the treatment is relevant for. So really being precise in how we're targeting our disease, our drug targeting disease targeting drugs. And that's important because I think that's underpinned, at least in part, why we've had issues with clinical trials in the field. Following on from biomarkers now, biomedical research has also given us great insight into risk factors as well. So we have really gained greater understanding in what risks there are and which ones we can potentially intervene on. With the recent Lancet Commission, for example, suggesting that up to 45% of dementia cases could be preventable. And these risk factors include things like reducing vascular damage, so reducing smoking, treating high blood pressure. And these are all factors that in part have been identified with biomedical research. And we have research that have also targeted these risk factor pathways as well. So I've gone quite quick, but to close, I think biomedical research funding provides us with a cure, with the kind of potential high impact on the lives of millions. And we're really on the edge of a new phase in dementia research. And I think now is the time to kind of capitalize on that momentum, keeping funding across the biomedical research space, moving towards disease modifying rather than understanding. And by funding purely kind of social care research over biomedical research, we are resigning to maintenance rather than prevention of the problem. So Nancy mentioned some of the numbers of kind of the cost and the kind of the rising exponential amount of people that would be diagnosed with diseases that cause dementia. But of course, if we don't stop this number is just going to keep growing. You know, if your house was on fire, would you support the people coming out of the building, or would you put the fire out and stop the house from burning down? And I think in this, biomedical research is our fire service. And whilst, of course, we should provide support for those that are impacted, without further research, we are just exposed to this kind of exponentially increasing problem. Thanks.
Very much. So now we thank you both for your opening statements, both very strong, passionate arguments. We're going to now move into our rebuttal and exchange period, a chance for you to respond directly to each other's points before we bring in the audience questions. Nancy, perhaps you'd like to start us off by responding to Soraya's arguments.
Okay, thank you. I want to be clear that I'm not anti-science. I'm more pro-human. I'm not saying that we should stop biomedical research. I'm arguing for a balance because right now the balance is profoundly uneven. I work for 2 nonprofits. Try getting grants for nonprofits to do qualitative and sometimes smaller scale types of research. For every dollar spent on improving how we care, dozens are spent chasing a cure that remains elusive. A future-focused science must also include the science of care. We're always here in the news and every single week in the newspapers and the latest magazines, we hear the latest drug, the latest research, we're so close to a cure. We've been close for 30 years now. Progress is slow because dementia is complex. Meanwhile, people are suffering now. And hope also means helping people live well today. Research in care is a form of hope that's immediate and humane. The public also wants a cure, without question. You hear all the time, I'm forgetting something. Does that mean I'm getting dementia? Does that mean I already have it? Of course, everyone is looking for that cure, but surveys show that families prioritize dignity, quality of life, and support more than speculative cures.
Thank you, Nancy. Soraya, would you like to respond to Nancy's points? I think you already did to some extent.
Maybe, but I have a few extra to kind of add to the rebuttal. So I think firstly to start with a kind of moral approach to social care research. I think I guess this is already re-emphasizing what I've said, but without progress towards a cure, we're condemning future generations to live through the same diseases. And as I said, this problem is only going to get bigger. And right now, if we're already at a point of kind of critical issue, this is only going to get worse. And I think really we're at the start of something exciting in the progress for treatments towards cures. And I said that, we have 48 trials in phase 3. So this isn't something that's 10 years down the line, 20 years down the line. We have modifying treatments that are coming through the pipeline. And whether it's amyloid, whether it's something else, I think we're really only going to progress and build. One thing I want to highlight is if we compare to cancer research, something that I think we compare to a bit as dementia researchers. The significant investment in cancer research has really yielded amazing breakthroughs. But cancer research gets 13 times as much funding compared to dementia research. And so for every 1 dementia researchers, there's 4 cancer researchers. And we know that cancer research has had this sustained, massive kind of prioritized funding over decades. And actually, the way that they've done this provides a biomedical, a blueprint that biomedical research can make a difference. It's not some kind of question that we may or may not get a cure. We know that based on other, disease fields, if we fund biomedical research, we do get a cascade of different treatments that can really have an impact on a person's quality of life and also towards a cure itself. No. Yeah, I'm just trying to think if there was anything else, but I think that's probably, if you wanted to say something, Adam, go for it.
No, not at all. I was just going to ask you, how do you respond to the view that cure-focused work can overshadow quality of life for people living with dementia right now?
So I think for sure it's important to acknowledge that right now, biomedical research, if we're focused towards a cure, that is a little bit down the line from where we are today. And we need to invest. It's kind of a capital investment for the future rather than exactly for today. However, across biomedical research, as I said, it's not just about a cure, it's about these risk factors, it's about the biomarkers, it's about at least being able to identify people that may go on to develop dementia so that they can maybe implement their own kind of interventions. We know that, like I said, 45% of dementia may be preventable in the sense of the risk factors that people can modify. And if they can't identify themselves early enough to maybe implement these preventions, and we can do this by developing biomarkers and other understanding on risk factors. So that's what I would say.
And in your opinion, does biomedical research have enough funding now?
For dementia, no. I think maybe Nancy and I can both agree on that regardless.
Nancy, and I assume your opinion will be that social care research doesn't have enough funding now. Yeah, I mean, you made that point at the start. So, Soraya, if funding was redirected towards social care, what risks do you see for the pace of discovery and prevention and modification or cure?
Well, I guess there's a number of different risks that I see. I think first, I've already highlighted this, but I think we're really on a positive, upward trajectory. We're on this very good momentum at the moment of having these disease modifying treatments that are in development. And I think if we underfund now, we risk losing this kind of onward momentum and learning from the lessons that we've been building on for many, many years.
But aren't they? I mean, I'm going to play devil's advocate here. Aren't they funded by pharmaceutical companies who are going to profit from them anyway?
I mean, I think in the long term,
Those
whoever
drug trials
fund
aren't funded by charities and public money, are they? Or are they?
well, I think some at least are in the. I know for sure, for example, if you're developing therapeutics within universities, you could then lead to spin outs to companies, and that would have been funded by charity research, government research. I know that there is also ways that you can do kind of outhouse, in-house, so looking at developing some research further, etc. But I think really the main point is that if we have a cure, we don't need the research funding because these diseases will be eradicated, and that is, I think, the end goal for everyone, right? So I think that is really what funding biomedical research gives us, is the fact that we won't need to do it in the future because in an ideal world everyone will be cured.
Nancy, I'm going to come to you. You argue that more funding for social care would deliver immediate benefits. What specific outcomes should funders expect if money was redirected now?
That is always the question when it comes to qualitative research and when you're dealing with real lives and real people in real time. Uh, I can only speak from my own experience as a practitioner. I know when our techniques and our interventions work because I see people sitting up straighter in their chair. I see their eyes light up. I see them making more eye contact. I see them looking or even reaching out to someone sitting beside them. Uh, I I see people who have not been able to speak a complete sentence be able to complete a sentence uh, and actually speak when they are valued and communicated with and have this social interaction and the social engagement. I see it every day. How do I quantify that? And that is the goal of this my particular research. And I know there's software out there that you can do some really amazing facial and body language um, research and results, get results from that. And And there are biomarkers where my clients could wear a watch or wear something like that would measure heartbeat and pulse rate when those interactions take place. And those things are important because then that would prove that our interventions do work. The techniques that I use in my day center every single day and that I will do again tomorrow will work when but in terms of the biomedical research, when I walk into my day center tomorrow and see my 30 clients living with advanced dementia, it won't do them any good at all. Won't do them any good at all.
Actually, so Soraya, that leads me to a question for you. So, should biomedical research success be judged only by scientific discovery or by eventual real-world benefit? Because you mentioned lots of progress in things like gut-brain axis, neuroinflammation, all these things which in themselves add to this body of evidence. But are they delivering, do they deliver real-world benefit?
I think, in my view, there are obviously two different aspects, but the end goal for biomedical research is real-world impact. So I've mentioned the kind of amyloid drugs, and they have a kind of modest effect, but it's still an effect. And potentially now that may not be as impactful as we'd like, for example. They're just an early stage into where we think we can go. So maybe a 35% reduction, I forget the exact number, of cognitive decline over 18 months is not so much now. But actually, as we progress, like, I can see, the end goals for our reduction is normally a reduction in cognitive decline, for example, plus a change in biomarkers. And whilst maybe, some change in cognitive decline seems quite minuscule at the start, I think as we add on and build up to it, if it helps a few patients even, preserve some of their cognitive abilities for months longer, I think that that's really, really valuable. And that is something that we aim for with our kind of biomedical research.
Yeah. Okay. And Nancy, if a percentage of funding was moved to social care, where would you invest that first and why? Because this is the tricky part as well, isn't it? I mean, would you
Yeah.
put that into the prevention stage, or would you put that into improved palliative care? Or because one of the risks we know from the disease modifying treatments that we've seen that the ones we have right now and the progress we're likely to see, Soraya, tell me if you disagree, in the next, say, 5 to 10 years is going to be to significantly delay onset or pause people at the point they've arrived. It can't regrow the brain. It can't fix things.
Right.
And so what we potentially have is a population, an even larger population of people living with more moderate symptoms, potentially. Do you think then, so where would you invest that? And are we saying that there comes a point where there does need to perhaps be a rebalancing, but would you argue that that's just not arrived yet?
It certainly has not arrived yet. I think a lot more funding needs to go into community-based programs. I think ideally, if people can live in their own homes, if that is their choice and that is where they receive the most dignified self-identity, and that's possible for the families, I think that's where the investment should come. Um, like the day centers, for instance, nursing homes and communities and assisted livings are important and needed, and some people choose to do that, but many people do not. And so I think community-based programs would be particularly important, dementia-friendly communities, and family support. I am constantly in touch with my families who are always asking questions. What do I do about this? What do I do about that? It also depends upon the phase of dementia. If you're in the earlier phases of dementia, then the family's needs and the person's needs is so different than someone like my clients who are in more of the advanced stages where they have limited verbal ability. And they're not as mobile because of the physical deterioration. I have clients who are young onset. My clients range from 60 years of age to 100. And what our psychogeriatricians have told us that by their participation in a community-based center where they have activities that are meaningful and therapeutic, which we do, our particular center is a therapeutic memory day center, that their cognitive abilities, their neurological testing has remained the same for a lot longer. They're able to reduce medication usage. And they're much more engaged when that happens. I see evidence of that all the time. So it's a tough call. Families
I-
need support and communities need support.
Yeah, and I can see how that there comes a point where a balancing is necessary, particularly if once we've discovered what we need to discover. So I have one last question, and then we're going to move to our audience questions, which is, which areas of biomedical work do you think will be most vulnerable to a funding reduction, and what would be lost?
Oh, I thought you were going to ask the other way, so I'd already started answering the other way in my head. Most vulnerable to a funding cut. I guess in my perspective, that would likely be those more kind of novel ideas that go a little bit against the grain. So we have for example, in Alzheimer's disease, we have kind of the pathological hallmarks. Same with other diseases that are neurodegenerative. So for Alzheimer's, it's amyloid and tau. And there's a very big focus on those proteins, let's say, and then the impact that that has. However, I've mentioned some of the kind of more niche approaches, let's say, but still very much valued and probably still very important. We just don't fully understand how yet, but I think those ideas would become less funded or kind of less developed as there's just not as much of a workforce within those ranges. And I mean, we talked about kind of underfunding of research, of course, like if we had more funding, those ideas would get more fleshed out and we would know for sure whether, they're worth pursuing or not. But I think those would be most vulnerable. And I think they could be some of the most important.
The higher risk, higher reward
Yeah.
areas. Okay, let's go to our audience questions. Jack asked the first question. Considering dementia care costs will nearly triple in the coming decade, Alzheimer's Society projects 40.7 billion care costs by 2040. What funding models would advocate to ensure sustainability, avoid placing the burden on individuals? What kind of funding model would you like to see, Nancy? How should this be decided? I mean, we can't just say we should move some money from one place to the other. What underlying mechanism do you think should be decided to fairly reach a settlement?
With all the funding cuts everywhere, that's a tough one. Government, I think everybody needs to partner in the funding allocation. Government needs to partner, foundations need to partner, individual donors need to partner, and the families themselves, perhaps more on a sliding scale rather than um, the cost of care. I know that if you go private, and some places are more posh than others, it depends on how much money you have, on the type of care you get. That doesn't seem equitable, or ethical in many ways. And that's where training comes in. I think it has to be a partnership. community, government, foundations. It has to be a partnership.
What do you think, Soraya?
I think, to be honest, I agree. Yeah.
Do you think we should, I mean, both of you, do you think the public should have more say in this? I know that obviously at the moment there's the likes of the James Lind Alliance, which organise priority setting partnerships to decide what the priorities should be. And in the past, when they've been done in Alzheimer's, care has generally come out higher, whereas in other diseases like Parkinson's disease, it was cure that came out higher. And I don't know what the underlying psychology behind that, or whether in Alzheimer's it's more carers that reply to those kind of polls, whereas in Parkinson's it's people living with the disease themselves. But do you think the public should have more say in this?
Their taxpayer monies are going toward, I think it's just, I
for
think
the
that's important.
NIHR and MRC, some of those funding bodies, it certainly is. Obviously, less so with the charities. I guess I don't know if anybody's watching this evening and you're from a charity. I'd love to know how you prioritize.
I was going to say, from my perspective, I know for all the charity funding I've gone for in the past year has involved people with lived experience. So I guess, I think the public should have a perspective on where their funding is going, because it's tax, we're putting money towards it. They should have an input. And actually, I think the charities appreciate that. Like I said, for me, I'm representing biomedical research, and for each of my interview panels and also my grant, the review board. So when they're looking at the funding applications, they've had input from people with lived experience to really understand what is the longer term value of this piece of biomedical research. And I think that's been important for people that have lived experience, but also for researchers, biomedical researchers, of course, in particular, because I'm talking from my own perspective. But it's allowing us to really think about the kind of end goal, leading towards a world where we don't have diseases that cause dementia.
Yeah. And so we've got at a point here from somebody who kind of agrees, which asks the same question I do: is what do people living with dementia say about biomedical versus social care? Is the data available? I'm not sure it is. I'm not sure we've particularly asked that question. And Soraya, you make a good point. I think of course, you do have the likes of Alzheimer's Research UK that don't fund care research. That as an organisation, I suppose it's a trickier question perhaps for Alzheimer's Society in the UK anyway, or certainly Alzheimer's Association in the US, or other charities across Europe and other parts of the world where they do fund both. I'm guessing that their trustees are involved in that, and as an organisation, they set priorities and do their best to balance out the needs. So I think we answer your question there. We're not entirely sure, Brendan. But if you're watching this back recorded and you're from a charity, tell us how do you arrive at these decisions, because they're incredibly difficult. I think one of the tricky things, maybe less so in politics. In politics and government funding, do you feel like the disease? I mean, we're going to make an argument now for more dementia funding as a whole. For everybody, is how do politicians make the decision on where they think priorities should lie? Seems to be I'm sure they would argue that they get evidence from scientists and professionals who feed them information, but ultimately things like certain diseases just seem to resonate more with the individuals. I don't know if either of you. But if that is the case, you'd expect that dementia would do pretty well, but given how many people we know it affects.
I mean, for me, I'm going to chime in first, but then Nancy, of course, add something if you want. But I think really there's been a shift from thinking that that dementia is just something that happens and we can't do anything about, to kind of progressing to we have this understanding that we know we can effectively target it. Whereas when we compare, I've been comparing to cancer, and I'll compare back to cancer again, because that is one of the other big research funded areas. I think people can really resonate with kind of being like, there is a lump in my, I've got a lump, I know that this is something physical that I can actually, remove. I can then have radiation, I can then have chemotherapy. Whereas, if you're slightly forgetful, etc., of course we know that it's not just that. If someone's just slightly lost or whatever, you could just kind of dismiss it as something that maybe isn't that important. And I do think we've really seen a shift in that, both in kind of awareness campaigns and, the really great work building on this to make it understandable for the public to know that we can actually try and work towards curing this. Whereas I think before it was just something that, you're already old, we don't need to worry about this, it's not an issue really that we need to deal with. Whereas I think now we're really appreciating that it is something that we can work with and, work towards curing.
So we're going to take another audience. Sorry, Dementia, go ahead. No,
yeah, and also I believe that some diseases, cancer in particular, you mentioned Parkinson's, people want, when they give money, they want to hope that some people can get better. This might sound kind of crass, but we struggle. I work for 2 nonprofits, and we struggle for any kind of funding, any kind of donations. And it's like kids and cancer sell because
Yeah.
there's hope. People want to believe that when they give their money, there's going to be a cure. That person's going to be better, or that person is going to live a longer life. And it's going to be soon. It's not going to be 10, 15 years down the line. And I think with the prevalence in the press, and people just, and more people know someone in their family or friends or in their community who live with dementia, know that right now there's not any cure. And so why put their money into something that these people are older and they're going to die anyway? We found that out during COVID-19. We found hospitals and the medical profession had to prioritize younger life over older life. I mean, it happened. And I think that's also a problem for our funding.
it is. I mean, you can see it for. I mean, it's interesting. I'm sure I can't remember if somebody used to do this or I read it somewhere, but I seem to recall if you made a charity donation, having like being asked an opinion as to where you thought that should be directed to. Should it go to this, that, or the other? Because it's not so easy. It's not like it's like your council tax bill in the UK. So you can't say, "Well, I'm going to fund roads,"
just
and I'm not
bins.
going to. Yeah, exactly. It's not that simple, is it?
No.
We're going to take another audience question. John asks, let me spotlight this question. Can biomedical and social models be integrated effectively, or are they fundamentally at odds with each other? What do we think? Can we join things up to balance things out? Could you add on a social element, Soraya, to your studies to bring more people in so that they benefit during the life of the study, not just waiting for a discovery at the end?
I think for sure. Yeah, I mean, for sure, we should be integrating more things together. I think I will go back to one of the points I did make about kind of risk factors and also biomarkers. So already biomedical kind of progress and tools is kind of underpinning various aspects of social care research. So we are already kind of working together in a sense that, we are providing diagnostic tools, we are providing kind of discrete patient populations that can then be more effectively targeted for social care interventions, for example, because I guess maybe someone with frontotemporal dementia versus Alzheimer's versus, of course, Parkinson's, for example, like they would have very different social care interventions, I would imagine, especially based on how the disease is affecting their cognitive modalities. So whether it's language, whether it's movement, whether it's memory, and actually, biomarkers are providing us these kind of better ways of classifying these patient categories, which I think then can really only lend itself to better social care interventions.
It's interesting because I guess, I mean, we're talking about biomedical research, but I mean, it leads into a lot of clinical studies that do involve real people. I guess it's the more fundamental, the stuff that very much is in the lab that's less so.
Yeah,
Um,
And
just
I
oh no,
agree. I
Nancy,
think
go.
there's definitely I would welcome the this and the use of biomarkers and testing saliva for cortisone levels and I would welcome up because that would also lend credibility and evidence to the techniques and the models that I use in my day center. What works, what doesn't work, what works for one person and why doesn't it work for another? And I think both models need to step into each other's world. Like try to step in the world of the other person with dementia to try to feel what they're feeling in the moment and be with them in the moment. Uh, um, a medical researcher needs to spend some time with real people in a real setting to see what that's like.
Yeah.
And as a practitioner and a social care researcher, I would welcome the opportunity to find out more about how we could partner together without question.
right. So we've got a couple of quite long questions. I'm going to jump through the couple of short ones first of all, because we are running slightly out of time. Somebody here makes the point, more of a point than a question. Diana says, another argument in favour of investing in social care is that research is easily translatable to other disease and improvements achieved in this area and not only benefit people with dementia, but people affected with other conditions as well. I'm sure Soraya could equally argue that any discoveries you make in one area of dementia could potentially benefit
100%.
in the same way. Right, let's get to a couple of these longer questions and see if we can work these out. So how should we prioritize funding between curing well, that's kind of the whole point. I think I think we've answered your question 2A. 2B, should part of the overall funding redirected to prepare the NHS or similar agency for the modifying treatments? Well, we're seeing that now, aren't we? That's the pressure from both UK charities and the Alzheimer's Association in the US are making these points that healthcare system preparedness.
Yeah.
So should funding for both areas be diverted into system preparedness? You're both going to lose out to healthcare to be ready for this. I'm sure you will both argue that you don't want that.
For sure.
Okay. Thanks for that. We'll look at Jack's third question now, which is only a small proportion of people with dementia are offered research participation. How would you address the design? So this is a good point, Nancy. So you've got some of Soraya's money. You're gonna now invest it in social care. How do you do better at making sure that it isn't just the wealthiest people that are good at asking for support that get that?
Because I think that's where community and government support is so important, that it should be accessible to the rural areas, to lower middle incomes, to um, people with disabilities. I mean, the interventions that I use in my day center for people living with advanced dementia, most of it can translate to people with disabilities. Then we look at the digital divide. When I did my research with my group online, I had to limit those who had internet connection, those who had a laptop or a smartphone where they could connect. And the digital divide is also very important. And I involved my clients and their families and their caregivers in the design of my project. I have them right there. We do that all the time, and I'm involved in a research project now about cognition, and people living with dementia has been part of the design of that project. But see, these are small, they're pilot projects. Funding is so difficult, and so you don't know about it so much until we can publish papers and get it out there.
Okay, we're out of time. I'm going to invite you both just to, I'm not going to give you full time. I'm going to give you both a minute to make your final point.
I thought so.
So, Nancy, I'm going to let you go first. You've got a minute from now, and I'm going to post the link for the poll while you're making that one.
Okay. When we fund care research, we're funding hope that arrives now and not years from now. We're funding inclusion for those often left behind. We're funding the possibility that every person living with dementia can still experience meaning, belonging, purpose, and self-identity. So tonight, I ask you to think about what kind of progress you want to support. One that may one day change a molecule, or one that can change a life tomorrow morning. Redirecting our priorities is not turning away from science. It's pro-human. Let's choose to invest in care that sees the whole person, not just the pathology, in research that builds communities, not just laboratories. Because a cure may come someday, and we hope that it does, but care is what makes life worth living every day.
Thank you, Nancy. And Soraya?
So I think I want to close by thinking about a car with a broken engine. So if you were looking as kind of social care researchers like continually making patch repairs rather than fixing the whole car, then this would only postpone the problem and be far more expensive in the long term and have a far greater impact on a much larger population of people. And we only know that this problem is only going to get worse. Investment in biomedical research is a capital investment that really retires this perpetual cost of trying to patch up the problem or just trying to help support people, when really we know from other fields such as cancer, if we put funding into biomedical research, we will get outcomes that can help improve a person's life. And really, for example, with biomedical diagnostics as well, they provide the why for social care research. So we provide, like with biomedical research, we provide the kind of diagnoses, the patient populations based on the measures that we can read from patients. And without this insight, these social care interventions may end up just being fruitless. And so to kind of finish, we're on the precipice, especially in dementia research, of a new age, one that we should really fully grasp, and one where we look to move towards finding a cure rather than just understanding the disease in biomedical research. And the cost of a cure is the investment in the future. And the only real way as well to stop this increasing development of this problem. So I think we should choose the path that ends these diseases and not just one that manages it.
Thank you very much. Both very compelling arguments. I would give both of you all my money. I'd encourage everybody watching now to participate in our closing poll. So you'll remember, I'll share my screen in a minute. There's a link in the comments that you can do. You'll remember that the motion here is that the House would redirect funding from biomedical dementia research to social care research. Nancy argued in favor of that motion, and Soraya argued against the House. And you'll remember at the start of today, 50% agreed with Nancy, 38% agreed with Soraya, and 13% of you were undecided. I'm gonna present on the findings on the screen now.
You're
but
laughing.
Keep posting. I can see the results. So keep voting. We haven't had as many votes at the end as we've had at the start. So keep going. And this is live. This will change in real time as we go. So again, Nancy had the poll results at the start. You'll recall that Nancy's arguments were that we haven't got enough money into social care research and that this will benefit people straight away now. Soraya argues that we're making real progress and that any diversion of funds away from this would have a massive knock-on effect, and that this would then cause the social care problem to last for longer than it would do, because we'll be caring for those people for longer because we won't get to the cure that we need. I think I've made both your arguments, and I'm going to argue, and we all fully agree that in an ideal world there will be sufficient funding for everybody to allow us to do both, and that if the disease-modifying treatments come through like we hope, we're certainly going to need more social care funding, certainly in the short term, while we look after those people who are taking those new treatments. Well, we're almost out of time now. I'm going to leave that poll on the screen for any very last minute voters. While that's on the screen, I'm going to find my final page of notes. Here we are, closing remarks, final votes. So my many thanks to Nancy Brown and to Soraya Meftah, who for joining us today, for all of you for taking part at home as well, and for both of you coming to debate this topic. Don't forget, you can continue the conversation in the chat below the discussion if you're watching this on recorded or live now. The polls won't be opened again, but thank you very much. We're going to be back in the salon next week, where we have Professor Terry Quinn from Glasgow, and Dr. Oh goodness me! And we've got Dr. Oscar Lazo, who are going to be both here next week. Oscar Lazo from UCL, Professor Terry Quinn from Glasgow, and they're going to be debating the House would make genetic testing for dementia risk available to everybody over the age of 40, with Oscar arguing in favour of that and Terry arguing against. So do join us next week in the salon. I think this is probably our final score now. So agreeing with the motion. Sorry, Soraya. But I think, if anything, what this shows is that we all agree that ideally we want both. And there's 50. I don't think 5% here is a big win. It's like one extra vote given the number of people who have voted live during this evening. But thank you very much, both of you, for so willingly coming forward to debate this topic. I really appreciate it, and it's great that we can have these conversations so openly and talk about these topics, because they're important and they're ones that are talked about in the streets and in the labs and in the NHS and streets up and down the country. Thank you very much, both of you, for joining us. That's all from me. I am Adam Smith, and this has been the Dementia Researcher Salon Debates. We'll see you at 8 o'clock next Wednesday for our next debate. Thank you. Take care.
What was the vote?